Assalamualaikum dear doctor. In this video I am discussing about limping child from NICE guideline. So first, the definition of limping of a child is that there is abnormal gait usually caused by any pain, weakness, deformity, usually characterized by shortened stance face on the affected side. Parents or carers may use the term limping to describe any abnormality of gait. Now, recognition and assessment of limping. First, history. There can be any trauma history, weight loss history, tiredness history, birth history including presentation at delivery and hip screening, development disorders, example cerebral palsy, fever, recent viral infection, joint swelling, joint stiffness, particularly early morning if considering inflammatory causes, sickle cell status, duration of the symptoms, and if delay in presentation, consider non-accidental injury. Now, examination. While examining in a limping child, that is observations including temperature, weight, look for rashes, pallor, lymphadenopathy, hepatosplenomegaly, torsion can present as limp. Examine testes. Piggles screening. So G for gait, pediatric piggles. G for gait, is it antalgic or Trendelenburg? Tiptoe walking, then heel walking. Arms, look for any restricted range of motion, stiffness, swelling and erythema. And legs, we look for bruising, deformity, erythema. Is the pelvis level and area leg length is equal. Feel for knee fusion and warmth, passive and active knee flexion with internal and external rotation of hip. Compare internal rotation of both hips. Restricted internal rotation is a sensitive sign of hip pathology. Spine. Observe from side and behind. Ask child to touch toes and observe curve. If joint abnormality found on screening examinations, more detailed look, feel, move, approach may be needed. Interaction between child and parents. If non-accidental injury mechanism may not fit injury found, then hip pathology can lead to pain in knee and vice versa. Now, differential diagnosis of limping. Always consider septic arthritis, malignancy and non-accidental injury as possible causes of limp in childhood. So, when a child present with limp, 0 to 3 years age, we think septic arthritis or osteomyelitis, developmental hip dysplasia and fracture or soft tissue injury, toddler's fracture, non-accidental injury. 3 to 10 years limping, the DDR, transient synovitis, irritable hip, septic arthritis, osteomyelitis, Perthes disease, fracture or soft tissue injury, stress fracture. 10 to 15 year, the DD of limping is that slip upper femoral epiphysis, septic arthritis, osteomyelitis, Perthes disease, fracture, soft tissue injury, stress fracture. Other important differential diagnosis of limping is, in all age groups, consider non-accidental injury, neoplastic disease, example acute lymphoblastic leukemia, hematological disease, example sickle cell anemia, infection disease, example polymyositis or discitis, metabolic disease, example rickets, neuromuscular disease, example cerebral palsy or muscular dystrophy, primary anatomical abnormality, example limb length inequality, rheumatological disease, example juvenile idiopathic arthritis. Now, the criteria of transient synovitis, that is, commonest atraumatic cause of limp, usually occurs in children aged 3 to 8 years, male predominance. Diagnosis with caution if age less than 3 years due to increased risk of non-accidental injury or septic arthritis. There is in transient synovitis, recent history of upper respiratory tract infection not always present. Child able to walk but in pain. Otherwise well, afebrile with normal systemic examinations, mild reduction of internal rotation of hip, diagnosis of exclusion, always consider septic arthritis, symptoms less than 48 hours and following brief period of observation, child systemically well, afebrile and able to weight bear, no further investigations necessary. Follow up in 48 hours and investigate if symptoms persist. Age more than 8 years and risk factors of slip upper femoral epiphysis, further investigation including anterior posterior and froglateral X-ray of pelvis. Now, septic arthritis. Septic arthritis, this criteria, if not treated urgently, joint destruction and growth arrest may occur, predominantly due to hematogenous spread. Blood clots are positive in majority cases, particularly prone joints is hip, ankle, shoulder, elbow. Staphylococcus aureus is the most common cause, can be caused by group B streptococcus in neonates. Age less than 18 months, more vulnerable as physis does not prevent blood entering epiphysis. Now, children aged less than 3 years are vulnerable to septic arthritis and non-accidental injury, with transient synovitis being a rare diagnosis. Investigate all age less than 3 years. Perthes disease. So, the Perthes disease criteria are idiopathic avascular necrosis of the capital femoral epiphysis, more common in boys aged 4 to 8 years. Perthes disease diagnosed on plain anteroposterior pelvic X-ray showing sclerosis, fragmentation and flattening of the capital femoral epiphysis may need bone scan or MRI. Symptoms more than 2 weeks and 20% is bilateral. Sleep upper femoral epiphysis. Typically affects children aged more than 10 years. Male predominance, other often overweight. And associated with hypothyroidism and growth hormone deficiency may present with knee pain. Hip can appear shortened and externally rotated in SUFI. Plain anterior-posterior films may be normal. There is lateral projections required if suspected. Urgent fixation improves outcome, can be bilateral. Now, very important is red flags of limping. So, when a child presents with limping, the red flags we need to exclude. That is, child age less than 3 years, unable to weight bear, pseudoparesis, fever, systemically unwell, lymphadenopathy or hepatosplenomegaly present or not, night pain and night sweats, multiple joint affected, symptoms lasting more than 6 weeks, child age more than 9 years with pain or restricted hip movement. Investigation we do for limping child is full blood count and blood film, ESR, CRP, if febrile, blood cultures, X-ray to views, site of pain and pelvis. If SUFI suspected, obtain anterior-posterior and frog-lateral views of pelvis. If suspicion of transient synovitis or septic arthritis, perform joint aspiration, microscopy and culture. This cannot usually be differential by ultrasound and require laboratory and clinical correction. Osteomyelitis or other abnormality suspected or no clear diagnosis with persisting symptoms, further investigation may be needed, may include MRI pelvis with or without contrast with pediatric radiologist. Bone scan, CT usually as addition to MRI or in unusual situations. Discuss with the pediatric radiologist. Creatine kinase and sickle screen. Now for septic arthritis, what the criteria we find: fever more than 38.5 degrees Celsius, unable to bear weight, ESR is more than 40 millimeter in first hour, CRP more than 20 milligram per liter, and white cell count more than 12 into 10 to the power 9 per liter. Septic arthritis can still be present in the absence of this criteria. So when we find a child is limping, then we first need to exclude the septic arthritis. That is one of the important red flag of limping child. Now, management of limping child. If any feature consisted with septic arthritis, severe pain, range of movement less than 75% normal, fever more than 38.5 degrees Celsius, unable to weight bear, ESR more than 40 millimeter in first hour, RP more than 20 milligram per liter, WBC more than 12 in 10 to the power 9 per liter, or X-ray abnormal or suggest orthopedic problem, example Perthes disease, SUFI. Refer to orthopedics for diagnostic aspirations. Washful before starting antibiotics. See osteomyelitis and septic arthritis guidelines. Now, discharge and follow-up of limping child. If blood test and X-ray is normal, irritable hip, reactive arthritis likely, discharge with analgesia, information, leaflet and reassurance. Advise return if fever occurs or problem becomes worse. Now, review after 5 weeks. That is, if worse, refer to the orthopedic opinion. If no worse, review after a further 5 days. If still no better, arrange joint orthopedic or pediatric review and consider referral for pediatric rheumatology opinion. If normal, at 5 or 10 days, discharge. So, this is all about the limping child from the NICE guideline. Thank you.